Okay, am I audible?
On a place on to right parabolic connection. Tube in C2.
Yes, you are, ma'am. You are audible.
Okay. So good evening, everyone. On the behalf of Dardia Pain Hospital, I welcome all of you for today's session on brachial plexus injury and its ultrasound evaluation. Myself, Dr. Kanchan Sharma. I'm a pain physician at Adhya Pain Management Center, Jaipur. And along with me, today we have Dr. Chinmoy and Dr. Debjyoti Datta. Both of them currently, they are working as consultant pain physician at Dardia Pain Hospital. And the speaker for today, we have a very good friend of mine, Dr. TCT Novi. She is a consultant physiatrist at Bangdang Hospital, Indonesia. She is the program director at Pain Management Network, and she is both CIPS and FIPP from World Institute of Pain, and she is also the director at WAPMU Indonesia chapter. So the plan for today is we are going to have a presentation for 40 minutes, followed by question and answers, and in the end, I will be sharing one very useful tip with all of you. And I'm sure this tip is going to be very, very useful for you, especially for the interscalene block. Okay, so over to you, Novi. Novi, are you there? We can't hear you, Novi.
Cannot?
We can't hear. Yes.
Can you hear me now?
Yes.
Okay. Thank you so much, dear Dr. Kanchan, for the very warm welcoming speech. And good afternoon to you all from Indonesia, dear professors and doctors. I'm honored to deliver a lecture. May I say lecture or just share with you all about brachial plexus injury and its ultrasound evaluation. Can you see my slide? Can you see my slide? Yes?
Yes, no.
Okay. First of all, I'd like to thank dear Dr. Gautam Das, my great teacher, one of my greatest teacher in pain management and international pain management. Because of him, I can become at the level right here, right now. I cannot forget the moment when I firstly asked by Dr. Gautam Das to deliver a lecture at 2015 to give a lecture in ICRA in Kolkata. Well, at the same time, at that time, I've intended to take my FIP and SIPS exam. So I'm very doubtful at the time whether I will join ICRA as a lecturer or take my FIP and SIPS exam. But finally, I took the ICRA as lecturer there, and I get rid of the FIP and SIPS exam. Well, eventually, I realized at that time that I must explore more and learn more to be able to pass the FIP and SIPS exam. And at 2017, I took the FIP and SIPS exam after I went to Dr. Gautam Das' place to get a private preparation from Dr. Gautam Das, sir, and I cannot forget also from Dr. Debjyoti Datta here. Thank you, Dr. Debjyoti, and also Dr. Musomi Datta. In that very tight schedule at that moment, I went to Nijmegen in 1 month time, and thank God I can pass both the FIP and SIPS exam at the first attempt. So again, I like to say thank you so much to Dr. Gautam Das, Dr. Deputy Duta, Dr. Masumi Datta, and all my great teachers here. And I'm very inspired by Dr. Gautam Das sir to be able to share my not so much knowledge and skill to all the doctors, maybe all over the world. Here, we made pain management network program just to show you, just in case you want to join us here. Okay, to be short, because we don't have so much time about the brachial plexus injury, I will start with a case of a 17 years old young male who was still in senior high school with ADL, activity of daily living independently, who has a lot of gadgets and laptop work. Dori, bisa dibesarin itunya? Okay, he has been suffered for pain that felt from his left neck to his left arm till his left hand. I want to make the screen bigger here. Okay, thank you. The numerating rating scale is ranging from 6 to 12 at the scales of 0 to 10. So you can imagine he frequently bumped his back and head to the wall to reduce the pain that he felt. And the sleeping and the studying were disturbed because of pain. There was no numbness, no tingling sensation, and he has no history of diseases. And from the history of treatment, he has already went for 11 years to many countries, including here in Indonesia, and has already got a lot of medication, including NSAID, muscle relaxant, opioid, and also steroid injection, intravenous ozone treatment. And the last interventional pain management that he got is PRP on his left shoulder. So then I examined him from the physical examination at the head and neck region. The range of motion were full, both sides, to all directions, and he felt stretch when did extension, flexion, bend to the right and to the left, and it felt at the upper back, more at the left side than at the right side. The Spaulding test was negative at both sides. Distraction test was negative both sides. There were trigger points at the upper back, left side. There's no pain on pressure on the cervical area and no pain on pressure also at the greater occipital nerve root area, both sides. From the upper extremity, the range of motion were full, both sides. No pain on movement. Hawking-Kennedy test was negative, both sides. Abdomen pressure test was negative. So then, at that time, I thought about the myofascial pain syndrome at the upper back, left side. Then I planned to give him interventional pain management for the myofascial pain syndrome, but his parents refused because he has already got a lot of myofascial trigger point syndrome, and the last time he got shots at the left shoulder using PRP. So then I, at that time, thinking hard, and while I looked at his left hand, it was pale. And when I felt it, it was colder and had more sweat than the right side. So I asked him, is there numbness or tingling sensation? But he said, no numbness, no tingling sensation. So can you imagine? I straight go to the sensory and motoric examination because of that finding, the last finding. The sensory from C4, C5, C6, C7 till T1 is reduced. The most is at the C6 and C7 level, 2 points over the 10 scales, and the muscle strength from the C4 till T1 is reduced also. The most prominent is at the C6, C7, and C5. This is how I proceed with the sensory and motoric examination. Here, my left hand, can you see it? Camera tolong. Here is the C4.
No, we cannot see that.
Cannot see? Here, can you see that? Okay. This is C4 corresponding to here in the screen, okay? C4, C5, this is C5, okay, here. And then I'll use another color here. Maybe it will be seen clearer. C4, C5, C6 here, okay? This is C7, C8, and T1. Okay, that's for the sensory. And for the motoric examination, this is C5, this is C6, can you see me? This is C7, this is C8, and this is T1. You see it? Okay, this is the general examination for sensory and muscle strength for the C5 till T1 nerve root. And there's no allodynia. The reflexes are normal both sides, the physiological reflexes, and there's no pathological reflexes. So then at the time, I think about this one, the brachial plexus. Why? Because from my examination, it led me to the brachial plexus injury. As we know, this is just reminding for you, for us all, that the brachial plexus consists of C5, C6, C7, C8, and T1 nerve root. At the paravertebral level here, the C5 and the C6 will merge, becomes upper trunk at the interscalene area here, and the C7 will goes alone, becomes the middle trunk, and the C8 and the T1 will becomes lower trunk. Each upper, middle, and lower trunk will give rise to the anterior division and posterior division. You can here, you can see here that the posterior one, this one, of each upper, middle, and lower trunk will become posterior cord here at the level of suprascapular region, while the anterior division of the upper and the middle trunk will become lateral cord here, and then the lower trunk anterior division will goes alone, become medial cord. From the root level, we can see here that it gives rise to dorsoscapular nerve at the level of C5, and from the upper trunk, it can be said also that from the upper trunk it divides into dorsoscapular nerve and suprascapular nerve and subclavius nerve. That's all, including from C5, C6, C7 will give rise to long thoracic nerve. Okay, and then from the lateral cord, there's branch also to give another color, green one here, lateral pectoral nerve, and from the posterior cord, there's branches to upper subscapular nerve, thoracodorsal nerve, and lower subscapular nerve. And from the medial cord, there's branches to medial cutaneous nerve of the forearm, medial cutaneous nerve of the arm, and medial pectoral nerve. Okay, then at the infraclavicular fossa, the lateral cord will give terminal cord to musculocutaneous nerve, this one, and the medial cord will give rise terminal cord to the ulnar nerve, while the medial nerve will get distribution from the lateral cord and the medial cord. Last but not least, from the posterior cord, they will branch to the axillary nerve and radial nerve. Okay, so this just to remind us all, if I get rid of the mark that I do just now, we will see a clearer image of the schematic view of the brachial plexus. Each of the terminal branch will give sensory innervation and motoric innervation to specific area of the skin and the muscle. As we can see here previously also, and this is the muscles, I will skip it. And this is the chart where we can see the whole innervation of the terminal branch. The dorsoscapular nerve will innervate the rhomboid muscles. Rhomboid major and minor. The suprascapular nerve will innervate the supraspinatus and infraspinatus, and the subclavian will innervate the subclavius, and then the long thoracic nerve to the serratus anterior muscle. And then the lateral pectoral will innervate the pectoral muscle. The upper subscapular will go to the subscapularis. Lower subscapular will go to subscapularis and teres major muscles. Thoracodorsal from the posterior cord will innervate the latissimus dorsi. And then the medial cutaneous forearm will innervate the sensory of the medial forearm. Medial cutaneous arm will give innervation to skin of the medial distal 1/3 of arm. And then the medial pectoral that will innervate the pectoral major and minor muscles. And then the terminal branch from the cord, musculocutaneous, radial, median, axillary, and ulnar nerve, which innervate the musculocutaneous, the biceps, this one, coracobrachialis and brachialis muscles. This is how the muscles act. The radial nerve will innervate the radial side of the muscles here, which acts to extend the wrist and hand, including the supinator and anconeus. And the median nerve will provide innervation to the volar muscles of the arm, wrist, and hand that acts to flex the wrist and hand. And the axillary nerve will go to deltoid and teres minor that will act to abduct the shoulder. And the last is ulnar nerve. Ulnar nerve will innervate the flexor carpi ulnaris, which will flex the wrist at the flexor ulnar part and all the instinct muscle of the wrist and hand. Okay, so by knowing the innervation of the brachial plexus, we can trace whether the pathology is happening at the root area here, or at the trunk level, or at the lateral cord level, or the musculocutaneous level. In my case, I assume that the pathology happens at the root level here. Okay, I will get rid of the mark here. Okay, So then, this is the innervation to the muscles. I've mentioned it previously. This is the muscles also, just the same but different chart. I will distribute it to you if you need it. And to differentiate the problems from upper motor neuron diseases, we must check the reflexes. Okay, this is the biceps reflex and triceps reflex, which innervate by C5, C6, and C6, C7. Okay, so then after we know the history taking, we know the physical exam taken from the distribution of innervation of the brachial plexus, we come to certain diagnosis, right? And then how then we can be reassured that it is the problem from the brachial plexus? Ultrasound can help us to make certain of our diagnosis. How the sonographic appearance of the brachial plexus? The postganglionic brachial plexus is evaluated in 4 main locations in the neck and chest. Here, the first one is at the paravertebral area. We can see the roots there. And then the second is at the interscalene level. We can see the roots and trunks there. And then the third is at the supraclavicular fossa, where we can see divisions. And then at the infraclavicular area, we can see the cords. Okay. The T1 is polyvisual at the neck because of the overlying of the first rib. So then it is best evaluated on MRI. Actually, at the old days, we think that MRI is superior, but then using ultrasound, we can do it also. This is at the level of the paravertebral scan, where we can see the roots. Here we put the probe at the cricothyroid level. Here's Adam's apple here. Okay, we translate the probe to the lateral side short axisly using linear probe, and we can see hopefully C5 or C6. C5 will be in between the posterior tubercle and anterior tubercle of the transverse process. At the right side is the anterior side, where there is common carotid artery. And we can do long axis view by rotating the probe 90 degrees. This is 5 nerve root. We translate the probe up a bit to see the C4 nerve root in between C4 transverse process. This is the C5, this is the C6. The difference between the C5 and C6 is that the anterior tubercle of the C6 level is higher than the posterior tubercle. At the right side here is anterior, and this is the carotid artery. Okay, and the yellow one is the C6 nerve root. Here, if I don't give mark, the appearance will be like this, black and white. But then if I do drawing, we will see the C6 nerve root. Okay, and then this is C7 nerve root short axis view. The C7 transverse process has only posterior tubercle, no anterior tubercle. And then we will see also vertebral artery. This is very dangerous area. This is anterior, and this is carotid artery with internal jugular vein compressed, and this is the nerve root. Okay. Then I will go to the next slide. From that side, we will go further downward to see the roots and trunks at the interscalene level. Here you can see C5 and C6 as upper trunk, and then C7 as middle trunk here. And hopefully we may see C8 also, that will together with T1 form the lower trunk. Okay, and then if we go downward further, we will see just above the first rib, subclavian artery, and at the lateral side, this is lateral, we will see the divisions of the brachial plexus here at the triangle. Okay, and then after we reach the clavicle, we cannot see anything. Then we go downward across the clavicle, and at the level of the pectoralis minor, with the coracoid as the landmark, we can see the lateral and posterior cord and the medial cord in the arm adducted like this, with the probe almost long axis-ly placed at the coracoid area here. Oops, sorry. But if we want to see it clearer, we may ask the patient to do abduction. Abduction and external rotation of the shoulder like this. Okay, and then put the probe at the alignment with the pectoralis minor, and the cord is placed here. You will see at the monitor. Okay, then I'll show you on the healthy subject here. Silakan. How we scan the brachial plexus. Okay, the healthy subject is changing clothes. While he changing clothes, proceed with the next slide of the samples of nerve root avulsion after trauma. We can see in long axis view, the C5 is intact, while the C6 is avulsed. Okay. And this is neuroma due to traction and stretch injury. Sini kepalanya yuk. Okay, we can see here C5, C6, C7, and C8. It appears more hypoechoic and swollen compared to the C6 and C8. Baring aja yuk. Okay, and then, okay, I'll show you how to scan the healthy subject. Okay, madap ke sana yuk. Okay. This is Mbak Aisyah. Mbak means sister. Okay. So we go to the cricothyroid level. Usually I don't want to put pillow on the patient's neck, but to make her comfortable right now, I let her use pillow, but ask her to extend her neck. Mbak Asih bisa gini. Oke, tengadah lagi boleh? Bantalnya taruh di pundak aja boleh? Terus Oke, tengadah. You can see the Adam's apple here. This is the cricothyroid. Okay, we put the linear probe transversely over the Adam's apple here. The left side will be your left side on the screen. Okay, sini. Okay, here is the trachea with the thyroid gland, just like sand over there at your left side, and then I proceed to the lateral side. We can see the carotid artery and internal jugular vein. I compress it, disappear the intervenous jugular vein, and then when I release the compression, it will become bigger. Okay, then I proceed to the lateral side. At the uppermost is the sternocleidomastoid muscle, and then I go further to the lateral side to the posterior. Okay, hopefully we will see C5 or C6 at this level. Okay, I go up a bit. Okay, this is C5. And this is, oh sorry, previously is C6. This is C6. This is, sini lagi. This is T1. Kasih color. You can see vertebral artery there with the C7 nerve root. Buang color. And I go up. This is C6. C6 will be in between anterior and posterior tubercle with the higher anterior tubercle. Then I go up here. This is C5. C5, and then I go up a bit more. You can see my hand here. And this is C4. Okay, freeze. Okay. So you can see my hand there put at the cricothyroid level, and then translate the probe laterally to the posterior side. Minta tisu boleh? Oke. Review tolong. Yang pertama. Yang pertama. Yang pertama. Yang pertama. Okay. So this is trachea. Stop. Stop. Stop ini. Okay. This is trachea, okay? This is trachea. And this is thyroid gland. Okay, majuin lagi, play lagi. Okay. Okay, and then I go laterally. This is thyroid gland. Okay. And then I found carotid artery and internal jugular vein. Stop. This is carotid artery and internal jugular vein. It is compressed. Play lagi yuk. When I release the compression, the internal jugular vein will become bigger. Okay. Yeah. And then I go further to the posterior side. I go further to the posterior side. This is vertebral body, okay? Vertebral body. Go to the posterior side. I will find either C5 or C6 if I go at the level of the cricothyroid, okay? Stop. Stop. This is C7 actually because previously I see C6. This is the posterior tubercle. This is the vertebral artery, and this is and this is the C7 nerve root. While this one is vertebral artery. Okay, can you see it? If I draw it again, this vertebral artery, this is anterior side. Okay, vertebral artery with C7, and this is the posterior tubercle. Posterior tubercle. C7 has already posterior tubercle, no anterior tubercle. Okay, play lagi. Okay, and I go up. Oh, stop. Okay, this is C6. This is the anterior tubercle. This is anterior tubercle. This is posterior tubercle with this is carotid artery, and this is internal jugular vein, and this is sternocleidomastoid muscle. Okay, and the nerve root is this one, the yellow one. This is C6 nerve root. Okay, if I get rid of the marks, it will be like this. We must do a little bit imagination. Okay, and this is our C6. Okay, this is C6. Play lagi yuk yang berikutnya. Okay, this is play. This is C7. Okay, we can see the posterior tubercle nicely seen. Stop. This is the vertebral artery, and this is internal jugular vein, and this is carotid artery with sternocleidomastoid muscle. Okay, I get rid of the marks, and this I come again with the marks. Okay, now you can see it. Okay, play. And then go up to the C6 level, translate the probe cranially a bit. Stop. Mundur sedikit. Terus. Stop. Okay, this is C6. This is the posterior tubercle. This is the anterior tubercle. Okay, can you see it now? This is the C6 nerve root. This is the posterior tubercle with the anterior tubercle. Okay, the C6 is in between the anterior and posterior tubercle. This is the internal jugular vein, and this is the carotid artery, and this is sternocleidomastoid muscles. This is anterior side, this is posterior side. Okay, and then if I get rid of the marks, can you see it now? Okay, play. And then I go up further till I see C5. Okay, go up further, and then we will see C5. Stop. In between anterior and posterior tubercle. Okay, this is the nerve root, C5 nerve root. This is the anterior, this is posterior tubercle. This is anterior tubercle. This is anterior. Okay, this is posterior side. And this is sternocleidomastoid muscle, internal jugular vein, and carotid artery. And if we see here white marks, this is a place to do medial branch block. Actually, it is articular pillar, but we will not talk about the articular pillar. We will talk about the nerve root only. The C5 is placed between anterior and posterior tubercle, which has the same height. Okay, if I get rid of the marks here, can you see it? Oh, C5 nerve root. Okay, and then go up, play you. Go up a bit more to see the C4. Okay, C4. C4. Where is it? Coba sampai ujung. Sampai ujung means till the end. Mundurin dikit. Okay, this is C4. This is C4. This is the posterior tubercle and the anterior tubercle. Okay. This is C4. Okay, so that's how we scan the C4, C5, C6, C7 nerve root. And then How about the trunk? Okay. Ini bisa dimunculin lagi, Dori. Okay, we go back to the cricothyroid level. Okay, then we will see sini trachea, thyroid gland, carotid artery, internal jugular vein with the sternocleidomastoid. Okay, muscles, and here hopefully we will see C5 or C6 nerve root. Okay, depthnya 4 yuk. Okay, this is C7. Kasih color with vertebral artery, buang color. Okay, we go back to the C6 level. You can see here the brachial plexus already here. Okay, at the uppermost is C5 and C6, and then when we arrive at the C7 level here, okay, we will see first at the anterior side is this is C7, this is C7, this is C6 and C5 nerve root. Okay, here is the vertebral artery. Okay, this is upper trunk, and this is the middle trunk. Okay, C7. This is C5, this is C6, and this is C7. Okay, at that level, if we want to see the C8, then we must go further downward. If I get rid of this one, okay, and get rid of this one, so we'll see here muscles. Okay, here is the anterior scalene muscle, and here at the back is the medial scalene muscle. Okay, so the brachial plexus lies in between the anterior scalene and the medial scalene. This is anterior side. Okay, this is internal jugular vein. If I get rid of the marks, okay, now we can see anterior and medial scalene muscle, and in between is the upper trunk and the middle trunk. Okay, play yuk dari depan. So first we review dulu dong. Okay, we start from the trachea to the thyroid gland and carotid artery and internal jugular vein, and this is sternocleidomastoid. Okay, and then we go to look for the C5 and C6. This is anterior scalene muscle. Okay, stop. Okay, this is the C7 transverse process. Okay, with the C7, C6, and C5 nerve root, and this is anterior scalene muscle and medial scalene. Okay, this is sternocleidomastoid muscle. The border here, sorry, till here, because this is longus colli muscle, and this is the medial scalene muscle. Okay, like that. Okay, then we'll look for the C8. Okay, C8. So from the home base, the cricothyroid level, okay, we go to see the carotid and internal jugular vein. We look for the C6 or this is C6 nerve root, and then go downward. This is C7, and go down further. Di fokus dong. Go down further. Our focus, our eyes keep on looking at the bubble form of the C5, C6, and C7, and go down till we find the subclavian artery here. Okay, we see the C8 nerve root here. C8 nerve root with the division of the upper, middle, and lower trunk. Here. This is the first rib. Okay, resume. Stop dulu. Okay, resume. This is the subclavian artery, and this is the first rib. And this is the, I give another color. This is the division of the upper, middle, and lower trunk. This is at the supraclavicular fossa. If I get rid of the mark, then can see it clearer now. Okay, and then goes down further. We will hit the clavicle, right? So there will be nothing there. We will not see anything. This is at the supraclavicular fossa. We hit the clavicle here. We see nothing, and then we come here. Minta jalan sini yuk. Stop sini yuk. We get to the infraclavicular fossa. If the patient's arm is adducted like this, then we put the probe like this. We look for the coracoid process here, and we will see the pectoralis minor here. This is the frisio. This is the lateral and posterior cord. And the medial cord here. This is pectoral minor muscle, and this is coracoid process. And this is the lateral and posterior cord with the cord, lateral, posterior, and medial cord. This is coracoid. Okay. If I get rid of the mark, then it will be like this. Okay, but if you want to see it clearer, then we ask the patient to abduct his shoulder like this. Sorry. Abduct the shoulder and do external rotation. So like this. Is okay. Okay, and then I put the probe. That's like this, along with the pectoralis minor muscles with the coracoid as landmark here. Okay, See here, cord. It's not clearly seen. Freeze you. No, stop. And freeze. Okay. Freeze you. You see the cord here. And this one. This is the pectoralis minor muscle. And over here, the coracoid process. Okay, if I get rid of the mark, and it will be like that. Okay, so then I will continue to the next slide. Minta tisu. Saya mau slide lagi, Dori. After we scan the root, trunk, division, and cord, then we will see some branches of the brachial plexus. The first one is the suprascapular nerve. The suprascapular nerve, if we memorize again the first slides, it is a branch of the upper trunk of the brachial plexus. It will innervate the supraspinatus and infraspinatus muscles. We can see here at the level of trunk at the interscalene muscle. At the anterior side is anterior muscle and the posterior side is the medial scalene muscle. We will see the upper trunk. From the upper trunk, there will be a branch to the suprascapular nerve that will go to under the omohyoid muscle here. This one. Okay. If there is injury to suprascapular nerve, just like at this slide examples, then the suprascapular nerve will be swollen here compared to the left side. Okay, and if we do long-axis view, we can see hourglass appearance where that the entrapment side or injury side, it will be bigger proximally or distally. Okay, and the effect of the suprascapular nerve injury that the supraspinatus and infraspinatus muscle will become weak, will become atrophy. Here we see at the upper slides. The below one is the normal infraspinatus and teres minor muscle. And then this is spinoaccessory nerve. I will skip it. The long thoracic nerve. The long thoracic nerve will innervate the serratus anterior muscle. It is a branch of C5, C6, and C7 nerve root. So we can see it at the middle scalene at the level of trunk here, and it will goes laterally there to the posterior side, to the lateral side of the suprascapular nerve. Okay, and then this is the case of long thoracic nerve where it is injured and then the serratus anterior muscle is denervated. Yes, Dr. Kansa? Phrenic nerve is located at the anterior scalene muscles. Okay, so then I'll show you how to scan the suprascapular nerve. Okay, we find first the upper trunk, start from here, sini, cricothyroid level, and then thyroid gland, carotid artery, internal jugular vein, and then go to the lateral side. You will see the C5 or C6. Hopefully, this is C5, this is C6, right? Okay, then our focus will be at the C5 and C6, but first let's find the C7. This is C7, okay? So our focus, our eyes will be on the upper trunk there, and then we translate the probe laterally, okay, and caudally. We will see something moving here. Boleh miring sedikit, miring semuanya. Stop dulu ke saya. Miring ke sana, mundur ke saya. Terus, oke, tengadah ya. This is cricothyroid level. Find the thyroid, carotid artery, internal jugular vein, and then we come to this. Fortunately, this is actually C7. Okay, at the C7 level, we will see the C5 and C6 nerve root nicely seen at the top. Okay, fokus di angka 2. I put the angka 1. Okay, I adjust the focus so we will see clearer on the 1 centimeter level. Okay, and I go downward. We will see something moving here. Okay, from the C5 and C6 level, black dot here. Okay, this is the suprascapular nerve. Okay, it will go to the here. Look, omohyoid muscles. Okay, this one here. This is the suprascapular nerve. Okay, if I go back there, then we will see here another structure at the level of the medial scalene here. There's long thoracic nerve. Long thoracic nerve that will go to the omohyoid muscles also. It will be placed lateral of the suprascapular nerve. Wait a moment. Find the C5 and C6 and then go down. You see the black dots there moving. Goes to the omohyoid muscles here. Okay. This. Okay. Video yang pertama yuk. Bukan yang kanan. Okay. This is cricothyroid, thyroid, carotid artery, and internal jugular vein. We will look for C5, C6, C7. Okay. Okay, this is upper trunk. Stop. This is upper trunk, C5 and C6. And this is middle trunk. Okay. Our eyes will be placed there, focus on the upper trunk and middle trunk, and then play you. We will find a branch of upper trunk, which is the suprascapular nerve that will goes there. Okay, majuin, see, mundurin, play aja. Okay, terus. video berikutnya. Okay, this is the suprascapular nerve. Goes to under the omohyoid muscle. This is the suprascapular nerve. Okay, goes to under his top. This is the omohyoid muscle. This is suprascapular nerve. And this one, I will give another. This is the long thoracic nerve. Okay, if we scan backwards, then the suprascapular nerve will goes back to the C5 and C6 trunk, C5 and C6 bundle of upper trunk, and the long thoracic nerve will go back to the medial scalene muscles. Okay, and then the last, the phrenic nerve. Ada lagi. We will find the anterior and middle scalene muscle here. Now you're familiar with the structure, right? Here we see the anterior scalene muscle. This is the level of C5, C6, sorry, this is C7. This is the phrenic nerve here. Freeze. This is C7. Okay. This is the anterior scalene muscle. Okay. And the phrenic nerve is this one. This is sternocleidoid muscle, and this is the middle scalene muscle. Okay, this is the phrenic nerve. If I get rid of it, okay. So then back to my slide. Okay. Mbak, udah, Mbak. Thank you. Back to my slide. My case is about, I think about C5 until T1 nerve root injury. Tapi tunggu dulu di situ ya. And I think about what is the cause. And I asked him that as a child, he used to play Smackdown. Do you know Smackdown? Bang, bang. And maybe that's the cause. With the myofasciatic Gerpold syndrome at the left upper back. And then I do ultrasound guided injection to the C6 because the most prominent symptoms happen to the C6 level. We can see here that I start with the cricothyroid level, put the linear transducer, put it there, then translate the probe laterally to the posterior side till we meet the C6 nerve root. Okay, and then this is what I found. Okay, this is anterior side. This is anterior side. Okay, because we see here carotid artery and internal jugular vein, right? And this is C6. I put another color here. This is anterior tubercle. This is posterior tubercle, right? And that one is the C6. I compare it with the right side. The left side is 0.11 centimeter square, while the right side is 0.008 centimeter square. This one, okay. And then I do C6 hydrodissection, and instantly the numerating rating scale becomes 0/10, no allodynia, no hyperhidrosis, and it's warmer now, the same at the right side. And I gave him then masa relaxan only and mecobalamin. And then he continued on several rehab workups because the muscles has been hypoatrophied for 11 years. And I followed up for the pain itself, for the hyperhidrosis and allodynia. It took some time, actually. It's not just simple as this. And the complication for the interventional pain management at that time is trauma to the subarachnoid, subdural, or epidural injection, and seizures if we don't see the structure there, and a lot of vital structures there. Okay, so the take-home message is that brachial plexus injury is challenging in diagnosing to be able to be treated well. So we need thoroughly knowledge of brachial plexus anatomy and its sensoric and motoric innervation to be able to do good physical examination. Then ultrasound may be helpful to show the brachial plexus injury site, and we can compare the structure to the contralateral side, which is healthy. Last but not least, interventional pain management is not a panacea. It's part of a holistic rehabilitation program to increase patients' quality of life. So thank you for your attention. You are invited to join us with Dr. Gautam Das the 2nd and 9th November for outpatient pain management program. You can register to this link. Okay, please feel free if there's question. Dr. Kansan.
Yeah, thank you, Dr. Thank you, Dr. Wonderful presentation.
Welcome.
And a very, very nice. And so let me summarize. Dr. Novi.
Yeah.
So you look at my finger, the anatomy, the various anatomical approaches, and then she talked about nerves. So you look at my this hand is visible. So this is a very simple trick. Plexus. This the way I have learned. So you
focus ya dari.
dermatomes. Okay. So this is your C5, C7, and T1. Fine. So
Yeah.
These two. Okay. The thumb and the index. So they are gonna be. Okay. I'm alone. So this is gonna be my. I'm going to combine this is going to be my inferior trunk. Fine. This is the ventral and this is the dorsal. So the division of all they are going to form the posterior division. All the have an anterior, all the so these are three trunks. C7 all alone. Then I think there is a lot from my side. Am I audible to all of you?
Yeah, I can hear you.
You are audible. Are you showing something, Dr.
I don't know why there is so much. Am I audible now?
Yes, audible, but
Some echo is there. I don't know what is the reason.
Mute everyone.
Boleh ke atas lagi. Bahasnya nggak apa-apa ke atas lagi. Udah.
Is it fine now? This is C6, C7, and C8 and T1. Okay? So this is going to form a middle trunk and then the inferior trunk. So all the anterior division, posterior division is here. The posterior division trunks, they are going to support the posterior compartment of arm and forearm. Fine? Very easy. Remember that? What will happen? These two anterior division, okay, will combine and this is going to form the lateral. This is the lateral aspect. And these is going to be all alone. This is going to form the medial cord. Fine? So lateral cord and this one is the posterior cord. Fine? And she talked about scan the roots. So you need to start from the midline. Okay? If you see laterally, you will be able to see thyroid and then you will visualize the carotid artery, the tubular vein. Okay? If you are able to see two tubercles, one tubercle bigger than the other, at the level of C6. Okay? If you scan and you are able to see only one tubercle, only one tubercle, so that is C7. Okay? So from C7, we were at so much of echo from my side. I don't know.
It's okay.
Okay, let me check. I really don't know why.
Oh, echo dari sini, Mat.
Okay, so it was from your this thing. Okay, no me. And I have been just trying to find out what exactly is happening. Okay, it was not from my side. Okay, so we will put our probe in the midline. So just think my probe, this phone as your probe. Okay, so we are going to put it over the midline, over cricoid cartilage. Okay, so now we will be moving laterally. Okay, so if we are going to move laterally, we are going to see the thyroid gland, carotid artery, internal jugular vein, and then if you are able to see one tubercle, you are at C7, you will be able to see an hypoechoic structure, that is going to be your C7. You move up, if you are able to see two tubercles, one big, one short, then you are at the level of C6. If you move up, if two tubercles again you are able to see, they are of equal height, you are at the level of C5. Okay, and this was very nicely explained by Novi. I think she has taken lots and lots of time to explain you each and every structure. Okay, then second thing, she talked about suprascapular nerve, which you will be able to see beneath the inferior belly of omohyoid. Then she talked about long thoracic nerve. You have to look for this nerve over middle scalene because it pierces that muscle and then it goes. Okay, for the phrenic nerve, you have to see over the anterior scalene. So all these things, they are very, very, very nicely explained many a times by Dr. Novi. So thank you, Dr. Novi, for such a wonderful presentation. And now I would ask Chinmoy boss, Dr. Chinmoy and Dr. Devjyoti, if they want to share something, or we can take up the questions.
Yeah, I think we can take up the questions. Actually, this is a very nice presentation, but this part is not that easy. I mean, like those who do the neck ultrasound, they can understand easily. But I mean, like finding the phrenic nerve or musculocutaneous or this one suprascapular nerve is not an easy task. So at least first thing is to understand which are the nerve roots, and then to trunk and then cords. I mean, like but nicely shown. So only practicing is the main thing. That's it. Let us take the question.
Okay. So Novi, we have one question for you. The intervention you mentioned the hydrodissection at C6 level. If pain persists, can we do C6 root ablation?
C6.
Yes.
Yes. So I start with the cricoterate level here and then goes to the lateral side to find the C5 or C6, right? I compare the left side from the right side, and it's already shown previously that it is swollen. And I proceed from the posterior side to the anterior side to the perinerve root of the C6. Can you hear me?
Yes, Novi, we can hear you.
Yeah, the approach is in plane from posterior to anterior to the perinerve root of the C6, left C6.
Okay.
Is that the question?
Ablation is okay. So there is one more question. Have you tested for POS in this patient? The patient which you were trying to just put up that case. Have you ever tested for POS, thoracic outlet syndrome?
Oh, no. It can be. It can be toss, it can be other thing, but it is a resolved case. The patient has already get healed. Firstly by the C6, then the C5. That's all, no toss. If there is toss, then there will be still symptoms from this patient. But of course, at the first time we make differential diagnosis, all the differential diagnosis must be put in, including the toss.
Okay. So any more questions from the audience? So no question? Okay. So as I have promised, I'm sharing a very good article with you. Novi, you switch off that sound is echoing.
No, I'm still on. Dimatiin. No, I'm still on.
When I'm again that echo is starting. That speaker volume from your side.
Volumenya terlalu besar katanya Dori. It's still too loud? Is it enough now?
Okay, now there is no echo. Again, that echo has started. Okay, am I audible now?
Yes.
Okay. So this article is all for all those anesthesiologists. I'm sure most of you must be knowing this, but still, this is for all those people who really don't know. So what we used to read previously was that stop light signal, traffic light signal when we are giving an interscalene nerve block. This is no more there in the literature. Okay, why? It is because go back and read this article. You can take a screenshot. Okay, it is because now this spotlight, we don't have three lights, means we don't have three nerve roots. We have only two nerve roots. Okay, so it was C5 and C6. They have found out that there is an intraneural splitting of C6. Okay, see, look at this picture. It is C5, C6. You have got an intraneural splitting, which they have found out. And you can go back and you can read this article. Now, what is the significance of this? Supposedly, you're performing an interscalene block, thinking that these are three, nerve roots, and your needle is somewhere in between this and this. So you are going to cause an intraneural damage. So that was the article which I really wanted to share with all of you. I hope you will go back and you will read this article. It's a very good article. Please go through it. And I think this is in Regional Anesthesia and Pain Medicine Journal, 2016 edition. So with that, I would like to conclude the session for today. So thank you, Dr. Novi, for a wonderful presentation. Thank you, Dr. Chinmoy and Dr. Devjyoti, for being there. And last, but the most important, thank you, our audiences, for joining us. And see you next Saturday at 5 p.m., hopefully with some more interesting and useful topics.
Can I have a question, please? It's Dr. Guru here.
Hello?
It's Dr. Guru here. Can I have a doubt cleared, please? Can I ask you one thing?
Sir.
Okay, this article which you have shown, is it a single case or it's a series of cases?
It's a cadaveric dissection thing.
Okay.
They have done a cadaveric dissection in a series of patients.
Okay.
And that's why, like, new things, they are trying to say that, even the SAP arrangement, what we used to read it before, that, that arrangement also needs to be changed. So we need to redefine this brachial plexus anatomy.
Okay. But actually, most of them, we have to rule out bifid C6. I think that's the one they are trying to say. Okay, right. Fine. One more thing, I think the traffic light signal, again, when you go down towards the upper trunk, even that will even appears horizontal traffic signal.
Yes, because you will see that C7, and then after that, you will be able to see that C8, and T1 will be coming from beneath, and then it will be joining that C8. That's what you want to tell?
No, I just wanted to say that.
Yes, boss. Dr. Guru, I can't hear you.
Will appear as a traffic signal.
Okay. So anything else anybody wants to add on or anybody wants to say, or we can conclude the session?
I think we did not hear what Dr. Guru said. He can say again.
Dr. Guru, could you please repeat what you were trying to tell us?
Okay.
I think you were not audible to.
Okay, we are talking about the traffic signal sign, traffic signal sign. So only thing what Kanchan's article says that we have to rule out the bifid C6. It's not in all the cases. I had heard about the bifid C6, but the thing is, previously we used to see the traffic signal, but when you go more down towards the trunk, even the upper trunk will appear like a traffic signal. So we should not think that is C5 and C6 and C7. So this is a technical thing. So don't inject in the trunk part. So if you think that it is intrascally, most probably you will end up in failure.
Thank you, Dr. Guru, for enlightening us again. Okay, so we'll be meeting up next Saturday at 5 p.m. again with some happening topics. So see you then. Take care and good night.
Bye. Bye, everyone.